The Neonatal Intensive Care Unit is a life-defining place for many infants, families, and caregivers. The place in which such events occur is often remembered for its sights, sounds, and smells, but the physical environment of the unit is far more than a memory tag. It can directly influence the quality of the experience for all of its inhabitants. A growing body of evidence demonstrates the profound impact of the physical environment on growth and development of the neonatal brain. The experience of a neonatal intensive care unit family is starkly different from a family that has given birth to a healthy newborn. Joy and celebration are replaced with fear and trepidation. The fragile life of a NICU baby is at stake and families must cope with an uncertain future. Often there are risks communicated during pregnancy that will increase anxiety not knowing what is to come post-birth. This fear of the unknown has an impact on all parents, and coping strategies are highly varied at the individual level. During the NICU stay, the infant is experiencing a critical period of brain development. During the second and third trimester, the brain is undergoing the most rapid period of brain growth and development the infant will ever experience. In utero, the fetus's sensory development would continue uninterrupted due to the high degree of control over the sensory development and sensory stimulation. While confined within the mother, the fetal environment is developmentally appropriate for auditory, tactile, olfactory, gustatory, and vestibular kinesthetic sensory exposure, while being shielded from visual stimulation. Normal sensory development progresses successively, starting with tactile, then progressing to vestibular, olfactory and gustatory, auditory, and finally visually. This correlates with the experiences of the fetus in the womb through normal growth and development. Touch is the first sense to develop in early fetal life. The sense of touch is essential for growth and development, communication, and learning. Touch is the first interaction between infants and parents, setting the foundation for future emotional and intellectual development. Parents touching and holding their infants is an important part of nurturing and is critical for developing the infant's emotional well-being. During the hospitalization of the preterm infant, much of the tactile stimulation received is in the form of medical interventions, many of which are painful. It is very important to ensure that infants receive positive tactile stimulation, such as a nurturing touch, which is provided by their parents or caregivers if the family is unavailable. Skin-to-skin care is the ideal form of tactile stimulation as it most replicates the conditions inside the womb. Preterm infants can easily be overstimulated by touch as they cannot modulate sensory input well. Even light touch or gentle stimulation can be overstimulating or irritating. For preterm infants, gentle, firm static containment, sometimes called quiet hands or hand hugs, should be utilized. The taste system is intact by 24 weeks of gestation, and preterm infants can respond to bitter, sweet, or salty flavors. While in the womb, the fetus can detect multiple tastes from the maternal diet in the amniotic fluid. Many of those tastes are also present in breast milk after birth. When fed after birth, the infant can use those smells and tastes to recognize their mother. Providing the scent and taste of mother's milk has been shown to promote infant cueing, sucking, and arousal in anticipation of eventual oral feedings. Providing oral care with mother's milk increases non-nutritive sucking, intake, and growth. The olfactory system is intact by 28 weeks of gestation. Many of the smells the hospitalized infant is exposed to are negative, such as cleaners, disinfectants, and alcohol. Future exposure to these scents may be associated with negative emotions. One of the most direct ways for the infant to experience the parent's scent is through skin-to-skin contact. This contact is not only important for sensory development but also for fostering a strong attachment between the infant and the parents. Maternal odor can also influence the infant's behavior by facilitating state regulation. The ability to control states enables the infant to process and respond to information about the environment and begins the brain's hardwiring of behavioral skills that will remain throughout that child's life. Self-regulation, a skill that begins to develop in infancy, plays a crucial role in coordinating and organizing motor activity, levels of arousal, and attention. This early development of self-regulation is not just important for infancy but also for later stages of life, including learning, planning, decision-making, complex sequential actions, and resisting temptation. As the child grows older, social interactions will depend upon the ability to self-regulate behaviors. Caregivers can optimize smell development by educating parents to maintain a scent-free unit for staff and encourage parents to limit the use of fragrances, like air fresheners and perfumes. Do not hold the infant if the parent or their clothes smell of smoke or any other harsh substances. Provide mother's scent when possible. This can occur with the use of a breast pad or soft cloth. Perform oral care with mother's milk. In utero, the fetus is continually exposed to low-frequency sounds from the mother's body and environment. The fetus will begin to recognize certain sounds from the mother, and after delivery, the infant can recognize some of these sounds, like the mother's voice. Preterm infants in the NICU are exposed to a variety of different, unfamiliar, and inconsistent voices and sounds from medical equipment and different caregivers. Sounds that are normal to adults can harm the infant's developing brain. During this time, the infant also receives multisensory exposure and often conflicting, such as providing calm and soothing words and touch, immediately followed by an invasive procedure like suctioning or obtaining a blood sample. While the ear is structurally developed by 20 weeks of gestation, the critical stages of auditory neurosensory development occur after 20 weeks of gestation up to about 6 months. Exposure to loud or excessive sounds during this developmental period, in the NICU or at home, can damage the fragile auditory system. During 25 to 29 weeks of gestation, the immature auditory system is functional, as the cochlear hair cells connect to the brainstem. Auditory stimulation at this time can stimulate a physiological response. Neural connections between the cochlea and auditory center in the brain are fully intact by 30 weeks of gestation. Excessively loud noises can cause changes in autonomic stability, such as changes in heart rate, blood pressure, respiratory pattern, and oxygenation. Exposure to very loud noises can also increase cerebral blood flow and increase the risk of developing intraventricular hemorrhage. In utero, the fetus is surrounded by amniotic fluid, and many of the sounds the fetus hears are low-frequency noises, like sounds from the mother's digestive tract and respirations. High-frequency sounds from the external environment are filtered through the maternal body and amniotic fluid and muted to 20 to 35 decibels. This protects the fetus's auditory system from exposure to high-frequency sounds before it is prepared to handle such input. After delivery, auditory development requires various external inputs from speech, music, and meaningful sound to continue functional development. Infants born preterm are no longer protected from loud or high-frequency sounds by their mothers. Many of the sounds the preterm infant is exposed to are at much higher frequencies than anything they would experience in the womb. In utero, the noise the fetus is exposed to is transmitted through amniotic fluid. After birth, noise is now transmitted via the air. Even short-term exposure to loud or unexpected sounds can cause changes in heart rate, blood pressure, and oxygen saturation. Even when the infant is asleep, loud noises can cause frequent arousals, which disrupt the quality and quantity of sleep. Interruptions in sleep can reduce the amount of time spent in REM sleep, which is required for the normal development of numerous sensory pathways, including the auditory system. The sounds an infant hears during the first 6 months of life help the infant's brain develop various auditory pathways to differentiate sounds. If background sounds exceed 60 decibels, where normal speaking is about 50 decibels, the infant's auditory system cannot differentiate sounds and fine-tune its auditory pathway. This inability to differentiate background sounds from speech can disrupt auditory development and cause permanent structural damage to the auditory system. Prolonged exposure to loud sounds and disruptive neurosensory development can lead to varying degrees of speech and language delays. In mild hearing loss, the infant may be unable to hear soft consonants, making words seem incomplete even when speaking loud enough. In moderate hearing loss, soft consonants are inaudible and speech is difficult. The American Academy of Pediatrics recommends that the sound level in the NICU should be maintained below 45 decibels. Despite this recommendation, most NICUs have noise levels that range between 38 and 90 decibels. Even when the NICU staff think they are being pretty quiet, their actual sound level is much higher. While there are numerous sources of noise in the NICU, the greatest contributor to noise comes from staff talking and conversations. Any intensive care unit is noisy. However, NICU caregivers should make every attempt to minimize excessive noise exposure. Due to their thick plastic walls, incubators may help diminish excessive noise. However, some older incubators not only do not decrease noise, but their normal operations increase it. Modern incubators have quieter motors, ranging between 47 and 55 decibels, but this is still greater than the goal of below 45 decibels. Noise generated inside the isolette, like crying, opening and closing porthole doors, or respiratory equipment, is likely to be amplified. As caregivers, your role in maintaining a quiet environment in the NICU is crucial. You should always be mindful of the sound level of your voice. Strategies to encourage appropriate auditory development include speaking as quietly as possible within patient bays and avoiding loud laughter or conversations is not just a guideline, it's a responsibility. Remember, excessive noise can negatively impact the health of our little patients. Avoid talking over incubator or allowing medical rounds too close to the bedside. Empty sloshing water in ventilator or CPAP tubing. Quiet alarms as quickly as possible, however, never disable alarms, as this creates a safety issue. Use blankets or covers over incubator to attempt to muffle the noise. Avoid placing items on incubator, do so gently if necessary. Never use the incubator as a writing surface as the noise of the writing utensil is amplified inside the isolette. Close incubator portholes, drawers, and any other parts of the isolette gently. If possible, minimize the noise from personal communication devices, but using non-audible alerts, such as vibration. Use padding on trash can lids, cupboard doors, and room doors to prevent slamming. Use ear muffs for infants on loud forms of mechanical ventilation or medical equipment. Also, consider ear muffs for infants within hearing distance of other infants on loud equipment. Safeguard both REM and non-REM sleep, but remember REM sleep is extremely beneficial. Individualize noise exposure to coincide with day-night cycles. Auditory exposure for infants less than 34 weeks gestation is often not required. In utero, auditory stimulation beyond the sound of the mother's voice is not needed for appropriate auditory development. So, infants born before 34 weeks gestation receive enough, and frequently excessive, auditory stimulation from their environment. However, parents should be encouraged to speak or read to their infant. Caregivers can model how to speak gently to the infant and encourage them to speak with their face in front of their infant within their visual field. Provide parents with information about recognizing the signs of overstimulation and reassure them that they are not doing anything wrong. The infant just needs rest. Music, especially live music, can help soothe term infants who can interact with their environment, but may not be helpful in preterm infants. Live music is unique as it is not played continuously, reducing the likelihood of overstimulation that can occur with continuous music from an electronic device. However, the most important sound for all infants to hear is the sound of their parent's voice. In utero, the fetus's circadian rhythm of heart rate, temperature, activity, and hormone release is influenced by maternal cues. By 28 to 32 weeks, the infant can differentiate between day and night by light exposure. Infants provided light that mimicked the normal day and night cycle experienced better weight gain, shorter length of stay, and better motor exam scores. It's important to note that exposure to artificial light can disrupt the normal circadian rhythms, potentially leading to adverse effects on the baby's health and development. The visual system is the last sense to develop. The structural components of the eyes are formed early in fetal life, but the neural connections develop during the last 12 weeks of pregnancy. During this period, brain activity stimulates the firing of neural cells in the retina, preparing it and the visual cortex for birth. The neural activity is generated by the nervous system to prepare the appropriate visual pathways well before any visual sensory input occurs. The fetus is normally not exposed to light or any visual stimulus until after term birth. During the last 8 to 10 weeks of gestation, the neurons in the visual cortex are stimulated to prepare and develop the visual system. The stimulation for vision development in utero occurs during REM sleep, which occupies most of fetal life. Adequate sleep is essential for healthy retinal development and intact pathways to the visual cortex. After term gestation, the visual system naturally continues to develop due to various visual stimulation, mainly light and patterns. The ability to distinguish colors, a milestone in visual development, does not become fully functional until 2 to 3 months after birth, even for preterm infants. This natural progression reassures parents and caregivers that their infant's visual system is developing as expected, and that exposure to colors is not needed until 2 to 3 months. The visual experience for term infants, a crucial aspect of their development, should be carefully curated by caregivers. This includes directing light onto objects rather than the infant's face, introducing novelty, and incorporating motion. The focal distance for term infants is 10 to 12 inches, and gradually increases with time and the ability to focus. The ideal position for visual exposure of the newborn is being cradled in the parent's arms where the infant can see their face, emphasizing the importance of caregiver involvement in this process. Exposing the immature visual system to contrasting colors or movement can induce the start response. Normal visual system development occurs between 24 and 40 weeks gestation without visual exposure. Visual stimulation provided to preterm infants can drastically alter the visual system's development. NICU graduates are commonly afflicted with retinopathy of prematurity, decreased visual acuity, refractive errors, strabismus, cortical visual impairment, deficits in color vision, and visual field defects. Preterm infants in the NICU should have safeguarded sleep, eyes protected from direct light, and reduced exposure to excessive light whenever possible. Preterm infants are often unable to protect their eyes from light exposure due to their eyelids being very thin and the eyelid muscles not being strong enough to keep the eyelid closed for long periods. Exposing the preterm infant to bright lights is painful and can result in decreased oxygenation, disrupted sleep patterns, altered state organization, and poor circadian rhythms. Before 32 weeks of gestation, infants have minimal ability to constrict their pupils and limit the amount of light entering their eyes. Because they cannot adequately protect their eyes from light exposure or communicate their discomfort, caregivers are responsible for protecting their eyes from direct light. Infants less than 28 weeks gestation should be exposed to only low levels of ambient light and always protected from bright light exposure. Infants 28 to 36 weeks gestation should be limited in their exposure to light enough to support undisturbed sleep. Continuous darkness, dim lighting, or bright lighting is optimal for the visual development of the preterm infant. Cycled lighting, where lights are kept on during the daylight hours and off during the night hours, may help the infant develop their circadian rhythms. While researchers debate if cycled lighting is appropriate for all infants, most agree that it has some benefits with minimal risk for harm. Caregivers can optimize visual neurodevelopment by protecting sleep, especially REM sleep, by creating a dark environment for sleeping. Use adjustable lighting at each bedside, and try to maintain a day and night cycle in the NICU. Use minimal amount of light needed to accurately assess and manage the infant, especially at night. Consider the use of pen lights and flashlights whenever possible. Protect the infant's eyes from direct light during assessments, rest periods, and after pupil dilation for eye exams. Use heavy incubator covers to limit excessive light exposure during sleep. Underside of these covers should be solid and dark-colored to minimize unnecessary visual stimulation. Mobiles and high-contrast patterned toys are suitable for use under supervision only with term infants and for periods of 5 to 10 minutes at a time. Limit visual stimuli early on, and focus on exposing the infant to their parents' faces. During the neonatal intensive care unit stay, the infant's brain development is very susceptible to external stimuli. Normally in this time period, the preterm infant should be in utero and sensory exposure limited. The full-term infant should be in constant contact with their parent and family, receiving constant nurturing at home. Instead, the infant is exposed to various sensory exposure, many of which are not consistent with optimizing development. When the infant is born preterm and admitted to the neonatal intensive care unit, the normal sensory experiences are interrupted and, often, noxious. Instead of the warm, dark, quiet environment of the womb, the infant's sensory system is overloaded with excessively loud noises from medical equipment and various, unfamiliar voices from multiple caregivers, bright lights, and various tactile stimulation from invasive and painful medical interventions. The outcomes of preterm infants with extended hospitalizations are influenced by numerous biologic, clinical, and psychosocial factors. Yet, the environment also has a significant effect of brain development and function. Positive brain and sensory development depends on appropriate sensory exposure, which normally occurs through contact and nurturing from the parents and family. Deprivation or separation from the parents, even briefly, can result in emotional disturbances and decreased motor activity. Further, deprivation of appropriate interaction can have long-lasting effects, with poor physical growth, developmental delay, and increased emotional and neurocognitive difficulties. Infants who lack social interaction due to hospitalization often show similarities to orphaned infants in terms of high risk of developmental impairment. The neonatal intensive care unit is not effective as the in utero for supporting sensory development. Exposure to painful procedures, stress, interrupted sleep, and a lack of parent engagement can have altered brain development, sensory modulation disorders, long-lasting effects in neurologic development, and parent-infant attachment. The parents should be encouraged to provide much of the sensory stimulation for the newborn. The nurse's role is to facilitate the parent's ability to provide this stimulation by teaching what stimulation is appropriate at each gestational age and ensure the infant receives appropriate interventions when the parents are not at the bedside. Sensory stimulation include the following: neurodevelopmentally appropriate positioning and educating and mentoring parents as to how to position and contain. Assessing the infant's sleep-wake cycle to ensure appropriate timing of intervention and cares. Providing protected sleep time and avoid sleep interruptions from lights, noises, and unnecessary disruption. Encourage early, frequent, and prolonged skin-to-skin contact. Ensure separation between the parents and infant is minimized. Encourage and coach parents to become active participants in their baby's care. Parents should be educated about signs of stress and pain as well as developmentally appropriate interventions to mitigate pain, and when to collaborate with caregivers for pain management. Infant feeding is optimized through cue-based and infant-driven breast or bottle feeding. During hospitalization, sleep is frequently interrupted for routine medical care and frequently not for social or nurturing reasons. A typical infant may be disturbed over 100 times during a 24-hour period. Interruptions to the normal sleep-wake cycle in infants can lead to impaired neurosensory development. Untreated pain and stress in newborns is associated with multiple adverse long-term outcomes. Exposure to unalleviated pain is associated with altered pain perceptions, abnormal cortisol responses to stress later in life, and changes in brain development and cognition. Chronic pain can affect growth, immune function, recovery, and length of hospitalization. Higher exposure to invasive procedures in the Neonatal Intensive Care Unit is associated with lower brain volumes, leading to poorer cognitive, visual motor, and behavioral outcomes. Infections and antimicrobial resistance pose a profound threat in the NICU, so special protective measures are emphasized. There are several reasons why babies in the Neonatal Intensive Care Unit are at risk for infection. Many NICU newborns are premature and, as a result, their immune systems are immature and weak. Those babies are also typically in the hospital for prolonged periods of time. As with any sustained hospitalization, necessary medical interventions may carry a risk of infection. Parents play a very important role in infection prevention. By practicing good hand hygiene and monitoring the hand hygiene of the care team, parents can greatly lessen the risk of their children contracting an infection. The NICU is designed as part of an overall security program to protect the physical safety of infants, families, and staff in the NICU. Control stations are located within close proximity and direct visibility of the entrance to the infant care area. The control point are situated so that all visitors must walk past the station to enter the unit. The need for security should be balanced with the needs for comfort and privacy of families and their infants. Technological devices are utilized in flexible and innovative manners within the design of the multiple bed or single infant room NICU schematic. Such technology, when utilized in conjunction with the thoughtful planning of the traffic patterns to and from and within the NICU space, support areas and family space, can facilitate a safe, yet open family-friendly area.
Neonatal intensive care units around the world were designed and built to help meet the hospital to support the medical, developmental, educational, emotional, and social needs of infants, families and staff. The ideal neonatal intensive care unit is one that provides neurodevelopmental support, facilitates extended contact with the parents, resembles the in utero stimuli as best as possible, and protects the infant from toxins, which include infectious agents and chemicals used in the hospital, and safety. The unit should be near delivery areas and have controlled access and egress. Each bed space should have adequate space to allow caregivers to move around the patient bed, easy access to power outlets, suction ports, and air and oxygen regulators. Hand disinfectants should be present near each bed space. Anyone entering the unit, employee or visitor, should thoroughly wash hands before entering the unit and before and after touching the patient.
Historically, multi-bed units were preferred due to space limitation within the hospital. Parent visitation was highly restricted and limited to viewing their baby through a window. More recently, single-family rooms with a single patient, twins, or multiples have gained popularity. The single-family layout allows the caregivers to create an individualized environment that can be modified to the infant's need. It also enhanced privacy, which is essential for developing a collaborative environment. Further, single-family room allows parents to parent in private instead of parenting in public, which allows for intimate moments of touching, stroking, singing, reading, and experiencing emotions. For example, Consider how a new father may act towards his newborn when he is in front of a group of nurses or other parents compared to being in a private room with only one or two others present. He may be more likely to touch, sing, or read to his infant when he knows he has privacy. Also consider how comfortable a mother would be to breastfeed to kangaroo care when provided with privacy compared to having a small crowd. Also, single-family rooms allow parent an area to sleep and stay overnight with their infant instead of having to leave their baby's bedside to return home to sleep. This allowed parents to spend more intimate bonding time with their infant. This transitioned into parents who developed a better understanding of their infant's behaviors after discharge. The unit design of single-family rooms or multi-patient units has various advantages and disadvantages for patients, families, and caregivers. Infants cared for in single-family rooms weighed more at discharge, had a greater rate of weight gain, required fewer medical procedures, had a lower gestational age at full enteral feed and less sepsis, showed better attention, less physiologic stress, less hypertonicity, less lethargy, and less pain. Single-family rooms are quieter than the open bay. However, infants in single rooms were exposed to longer periods of silence, and much of the noise exposure is mechanical from medical equipment rather than language exposure, which may lead to atypical language development. However, much of the language exposure in multi-bed rooms is blocked by ambient noise in the unit, and the speaking came from care providers, not the parents. Private patient rooms allowed the family greater privacy than multi-bed units. The major benefit of single-family rooms for the parents was enhanced privacy and greater parental satisfaction and experiences. Families of patients cared for in single-family rooms report that this layout allowed them to spend more intimate bonding time with their infant. This transitioned into the parents developing a better understanding of their infant's behaviors after discharge. Preterm infants cared for in single-family rooms experienced more hours of visitation. The increased privacy offered with single-family rooms improved family-centered care, parent satisfaction, and parent-infant bonding. While NICU unit design has transitioned to support the needs of infants and their families, these changes have influenced staff caregivers' experiences as they adjust to new workspaces, changes in visibility, and differences in how time is spent. Some of the changes have resulted in a shift from a centralized nursing station to decentralized stations located near patient rooms. Decentralized nursing stations place the nurses closer to the patient and near shared resource stations, but away from fellow nurses. While this may have led to less interaction with peer nursing, it increased the opportunities for nurses to cross paths with other interdisciplinary team members. The unit design influences how much time the nurse spends with the patient compared to other nurses. In units that have transitioned from multifamily to single-family rooms, nurses spent more time with their patients and less time at the alcove or nurse workstation, compared to nurses with a centralized nurses station. The single-family room design makes nurses more visible to patients and their families, but less visible to their peers. This may lead to feelings of isolation and decreased peer support. However, surveys comparing both unit designs found no differences in peer support. The single-family unit design is associated with more time walking between patient rooms. However, the major concern over unit design is related to proximity. Optimal unit design allows nurses to be near patients, supplies, and resources. Lastly, nurses in single-family rooms report greater support from their supervisors. This is likely since family units are new designs that often plan to place manager and educator offices centrally in the unit where they are highly visible to nurses. Open bays are more often older units with limited space. Manager offices on these units were often not even on the same floor as they were placed in available space, not the optimal space. While there is debate and conflict among nurses and hospital administrators about which unit layout is best or undesirable, the most important factor is family presence. Parenting interventions during neonatal care period can start a positive trajectory early and the effects accumulate over years. While unit design is important, the biggest consideration is how the unit design or hospital regulations may enhance or inhibit parent involvement and nurturing. Parents are not visitors, they are the parents of the sick infant. Providers should take advantage of every opportunity to include the parents and allow them to participate and provide sensory stimulation for their child despite the unit design. The hospital administrators and caregivers should work diligently to remove any barriers that obstruct the ability of the parents to be at their infant's bedside. However, infants should not be kept in isolation. If a family is experiencing challenges to being present at the bedside, other efforts should be made to help expose the infant to appropriate sensory stimulation. This could be with an open unit or shared space if appropriate, or involving volunteer or support staff to hold, rock, or speak to the infant. The Neonatal Intensive Care Unit is a challenging environment for new parents. No parent wants to have their newborn end up in the intensive care unit. Many mothers may be discharged and return home without their newborn. Parents meeting their child for the first time and seeing them connected to numerous, potentially invasive, medical devices is frightening. The noises and perception of the staff can enhance or inhibit the ability of parents to cope with this stress. The perception of the medical staff is highly influential on parental stress. This relates to their behavior, communication, willingness to involve parents, support services from the hospital or support groups with other current or former, the physical environment, and regulations and the manner in which they are enforced. Communication with the medical staff is at the core of what parents experience, positive or negative. Many parents report that the lack of quality communication with the nursing staff is a major source of stress. Here are some quotes from parents taken from a study by Williams et al.
I found it extremely stressful that I never really knew what was going on. Aside from a few nurses, most of the time when I asked a question about why my baby was doing something, for example the squeaky breathing, the nurses just said it was normal. However, most of them did not take the time to explain why he was doing such things or what was happening.
During 2 procedures no one was able to give us an update. One was told to last an hour and 3.5 hours later they were finished. We asked other nurses to check for us, but they were only told the procedure wasn't done. When he was admitted no one told us why other than his blood work was really bad, and 4 hours later we were finally able to come down to the Neonatal Intensive Care Unit. Someone could have explained more why he was rushed down from well baby. We were very fearful and anxious, which I believe could have been avoided with a little more communication.
Conversely, good communication with the medical staff was often reported to have had a positive impact on the parent's experience, for example.
What was helpful to me during our time here was the helpful nursing staff and great doctors. They were great at explaining things, and it was reassuring to know that my baby was getting the best care possible. Rounding is a great thing. Having the nurses sit down and explain what was truly going on with our baby helped to comfort us and lessen the stress we had.
Bedside manner relates to body language, behavior, and communication medical staff display when interacting with parents and families. This also encompasses attitude, professionalism, and manner of care expressed by the providers. Poor bedside manner was noted as a stressor. Examples of this manner included the following.
I was reprimanded rudely when I came back from lunch to find my baby had spit up on herself and pooped her diaper, and I changed her and cleaned her up in between her feeding time. Not okay. Some nurses are quite rude if you're not getting enough breast milk / don't have enough.
The most frustrating thing is when nurses don't try. For example, just hook the baby to the feeding tube so they can sit and talk on the phone. Yes, personal phone calls.
I love most of the nurses, but there are a few that I have seen to be careless and too rough with the babies. This made me highly upset because they were so careless and rough. That is unacceptable. These babies are tough, but they go through too much and are too precious to be treated that way.
Other parents expressed positive comments about the bedside manner of the medical staff, noting the positive impact that it had on their experiences.
The nursing staff, however, was very helpful in assisting and informing me about breastfeeding. One nurse was my favorite. She was so helpful and kind. I would describe her as compassionate and yet professional.
I really appreciated the nurses giving me my space, but still checking in on me from time to time. They were also very helpful with supplies for breastfeeding. They never seemed to get irritated or frustrated, which makes me as a parent feel more comfortable and at home.
Many parents expressed that they felt excluded from the process of caring for their infant or that they felt unwelcomed in the Neonatal Intensive Care Unit.
It also seemed like the nurses would rather do things themselves than have me do it, like feedings and baths. It seems like we are in the way, and that's frustrating. I was a little disappointed I did not get to witness my baby's first bath. I didn't know when they were planning to bathe her. Her nurse came by and told me that it wasn't her care hour, and it would be best if I was there then instead. It made me feel completely unwelcome, and as if I wasn't allowed to see my own child. I had a meltdown. I went back to my room and sobbed.
Communicating with other parents was a factor that reportedly helped to alleviate some of the stresses of having an infant in the NICU. Several women found comfort and support in their shared experiences.
Staying at hospital-based housing and talking to other families that have had their babies early is nice. Just hearing stories from other women that went through the same thing and their child is or was grown or older and going great gives me hope, and praying makes everything better. What was helpful to me during our time here was talking with other moms going through similar situations and being able to empathize and talk with them.
Numerous parents described the Neonatal Intensive Care Unit environment as either a stressor or highlight of their experience. This included things such as the physical environment of the unit as well as the rules and regulations that were enforced there.
Being able to call and visit 24/7 helped. Not being allowed to sleep here was stressful. Poor support trying to pump or breastfeed was stressful. Having rotating doctors was comforting because they all have different views about the situations and medical conditions.
Having to choose between family members to only allow for 3 at a time, lack of waiting area for visitors waiting their turn. Having to coordinate feeding times with the cafeteria hours, not eating due to cafeteria being closed after feedings. Put vending options by unit. Bathrooms available in unit. Very hard after surgery to walk far to use bathroom when the one bathroom for the unit is being used.
I feel it is not fair that every baby is not in a room with their parents. And parents not being able to stay, but wanting to be with their preemie child. Something needs to change with that. Because for parents who have never been through things like this, which is the unit, it is not fair to them. It's already that we parents are not able to take them home. To know you can't stay the night, I don't like. How is that you can visit 24 hours a day but not sleep? It's very stressful on parents.
Allowing families privacy will enhance the ability to provide family-centered care. Providers need to remember that the care of the sick newborn is the responsibility of the parent, and medical staff exist to assist them in doing what needs to be done while not usurping the parent's role. The early life environment has a drastic effect on later health and development. NICU caregivers have the greatest control over the environment surrounding the infant. By appropriately adjusting the environment to be neuroprotective and appropriate, the infant's neurodevelopment can be optimized.